I'm here for two reasons. One is that our dear friend Talia Cohen asked me how it could be helpful to the organization, and my first reflex was to say, why don't you organize an event in my office at 550 High Street in downtown Palo Alto. She took the invitation, and then Wilson Sonsini beat me with some better catering. So, you know, well done. And thank you very much to Wilson Sonsini. They're a great law firm. We work with them on many of our transactions, and they're also very people with great values across the firm. We're really lucky to have, and I'm particularly lucky to be interviewing Marty today. Marty was one of the architects of the modern internet. He was one of the co-founders of a company called Enterprise Integration Technologies, which basically was the first company chartered specifically to monetize the internet. That was in the 1990s. Things we take for granted today, you know, the HTTPS when you type a website. E-commerce, building blocks such as payments and deliveries. We owe that to Marty Tenenbaum and his team at that company. He then went on to start several other startups. He's an active board member here in Silicon Valley. He's also a PhD from Stanford. So you could call Marty a Silicon Valley person, which is great, and it's great for a tech maker like myself. That's one of the two main reasons why Marty's here today. The other reason he's here is because he's also the founder and chairman of an organization called Cancer Commons, which is a nonprofit organization that networks physicians, patients, and researchers. And Newsweek referred to the organization as the LinkedIn of cancer, which is probably better than the WeWork of cancer. And so, first question for you, Marty, if I may, is what does that mean to be the LinkedIn of cancer?
I think it's simply trying to network everyone who's involved in cancer, doctors, patients, researchers, and the bigger network that supports them, providers, payers, pharma, and what have you, because if we're going to make some headway on cancer, no one organization can do it alone. And as Neil pointed out, we have to be able to capture the data from every patient being treated in every possible way in order to be able to figure out what to do next, better for the next patient. And sadly, even having all of the data in the world might not be enough. We just don't know yet.
You've got obviously a very personal story as it relates to cancer, as a cancer survivor. What is it in your own fight that you consider as the main reasons why you're with us today?
Yeah, some combination of being smart, well-networked, and lucky. 20 years ago, or thereabouts, I was diagnosed with melanoma metastatic to liver. That was before any of these immunotherapies or targeted therapies were available, and this was a death sentence. There were, ultimately, I went to all of the local oncologists here, and if I had listened to any of them, I would be dead. I was fortunate enough to have paid it forward. I was doing some consulting for the National Cancer Institute, and the director of the NCI put me in touch with a fellow who was running the melanoma therapeutics program, and he introduced me to additional doctors on a national scale, and the choices that they were giving me were far more interesting and more likely to work than what I could experience locally. But the two things that every cancer patient who has exhausted kind of the standard things will soon find out is that there's no general agreement on what you should do. Everyone has a different opinion. And there's no way to really find out. The data isn't readily available, and the knowledge isn't readily available. And in fact, there's no one today who knows the optimal way to treat any cancer with all of the therapies that are currently available, and I'm including there both the approved therapies and the investigational ones. And the reason is that advanced cancers almost always have to be treated with a combination of drugs, a regimen, right? And there's, if you think about it, a very large number of possible combinations, right? An explosively large number. And there are far more interesting things to test where there's a rational reason to try to test them than there are patients on the planet to populate traditional clinical trials. And so in order to be able to make some progress, we have to find a more efficient way to learn, faster, cheaper, and one that really puts the patient first. And that's the common theme that you'll hear over and over again. That goes for every one of the kids that benefit from the ART program, right? These kids need, at least the ones who are not responding to the standard therapies. We need to figure out what's best for that kid and then be able to very quickly learn from that kid's experience what to do better for the next patient. In a continuous learning process where each patient is informing the treatment of the next patient in real time. And the system is just not set up to do that today.
And by system, you mean the overall healthcare system, or?
The overall, let's say, clinical research system. I mean, in a sentence, what I'm trying to say is that we need to very tightly integrate what goes on in the clinical research world with what goes on in the clinical care world so that there's no daylight, so that we're continuously learning from every patient on every treatment all the time. And that is not something which the medical establishment, and by that I mean my friends at Stanford, there's many of you in this audience, or at UCSF, right? It's a real challenge. Or the VCs that are willing to fund this kind of stuff against the prevailing wisdom, right? We need to be bolder as a community. And the people who are going to drive that, I couldn't agree with Anil more. It's going to be the patients. They're the ones who have skin in the game. Urgent. We can't wait. And the kids certainly can't wait.
And so how do you go about empowering patients, empowering all of us and our children to take charge?
It starts by one patient at a time, saying what's best for that patient. So the clinical trial system, as it's set up today, is focused on getting drugs approved. And we have some marvelous drugs that come along, but as I said, the challenge is not so much the individual drugs, it's how to put them together into a regimen, which may be very unique for each patient, right? But the challenge is that a system that's set up to approve drugs, you have all these trials competing for the same pool of patients, and they're competing greedily. And the problem, and it's a deep problem, and maybe even an ethical problem, is because I'm a good candidate for your drug, doesn't mean that your drug is the best treatment for me. So we've got to turn the whole system on its head and rethink it in a patient-focused way, where the goal is not to approve drugs, but to cure patients. And if we build a system like that, and start with a system that is primarily focused on each individual patient, right? And then we continuously learn, it becomes very straightforward. Everything becomes aligned because the goal is if something's working, put more patients into it and don't put the patients into things that are not working. You've heard the term fail fast. So if you don't have a drug that's like winning against other drugs, you'll only lose in the market later anyway. Cut your losses, go do something else. But for the sake of the patients, let's get a system that's efficient. And I can say this too, because I probably will forget to say it later. If any of you have a loved one who is dealing with cancer, come see us at Cancer Commons. It's a 501c3. Everything is supported by philanthropy. And you'll get advice that you won't get anywhere else in the world. One more plug, Sherry Sobrato is a big hero of ours. She's a big supporter of Cancer Commons too. Thank you, Sherry.
Thank you, Sherry. So, as a tech banker who works with a company that scale up quickly, how does one scale up a network like this?
Well, I think the good news is that informatics, information technology, is the key. If you have something that's helping a patient, and maybe you've done deep research to help that patient, just perhaps that solution may help 10 other patients who have similar cases, or maybe 1,000 other cases. But we have to figure out a way that's more efficient to get the word out than the 17th century technology. And by that I mean journals, conferences, right? The medical world still depends on that, right? A system that was devised in the 1600s for the British, the Royal Society, right? Which was revolutionary then. Now we have knowledge which is millions of times more knowledge that changes thousands of times faster, something like that. The old system can't possibly work. And to be able to say even that to read a medical paper, which goes on for 20 pages, where there might be a few sentences of actionable information buried in there, right? We've got to be able to do better. We've got to be able to get that information to the point of care where it's needed. And based on, here's the patient, here's the data from a deal or wherever it comes from, what information do I need to try to treat that patient better, based on the whole world's collective knowledge.
Fantastic. You've been in the capitalist environment most of your career. You're now running a nonprofit. Is it either or is there?
No. It's I'm going to take this out on layers for you. So the first thing is that nonprofits are uniquely good for some things, and they're very, very good as a trusted source of information, completely objective. We don't have any, horses in the game. We're just trying to do better for the patients. And we also have convening power. So no one organization can transform the system, nonprofit or for-profit. We've got to bring everyone to the table. And so Cancer Commons was named Commons, right, to be this common ground, to bring everyone together, to build the system that needs to be built. And that includes everyone, including the payers, the providers, the regulators, everyone, and the little startups, and the big, and the capital sources, right? But philanthropy and philanthropic type organizations have their limits. And if I said that informatics was the key to be able to scale things, that's not something that nonprofits are very good at, developing software. And so last year, or about 18 months ago, Cancer Commons actually spun off a for-profit company. The name is XCures with an S at it, after it, to develop the software and services to scale the N of 1 personalized recommendations, patient navigation that we do in order to be able to not just help many other patients, 10 or 100 patients who have similar cases, but to be able to capture what those patients did and how it worked in order to be able to drive learning of the whole. And not to just do it for Cancer Commons, but to do it for every organization that's trying to do what Cancer Commons does, and to build this learning network. So in order to be able to build that network, though, not only do we have to get everyone to the table, but we have to get everyone to agree on certain standards and standardized agreements and processes for being able to share data. And it's not just that I'm building this ecosystem and platform to benefit Cancer Commons. I'm building this platform in a many-to-many sense so that everyone who chooses to be a member of it can use the whole platform for whatever they want to do as well. But everything tied to the learning system, so everyone is continuously learning.
Thank you. I think Marty's very humble about the achievements of the organization. So I'll mention 3 numbers. Cancer Commons has helped 5,000 patients over the last 10 years in about 70 countries. So quite a remarkable achievement. And I think your experience as an entrepreneur in tech is really going to help push the organization forward, specifically as it scales up. Let's switch gears and talk about children,
Please.
Which is why we're here today. I can relate to my own personal, very humble situation. I'm lucky to not have to deal with cancer in my family, but we have a trilingual home. I speak French to my children. They're 9 and 7-year-old daughters. My American wife speaks Spanish to them, and they learn English on the playground and at school. And our pediatrician, very early in the lives of our daughters, gave us an incredible recommendation, which was to say, art. And art for what? Art to understand, art to settle, art to, it's not a verb, to abstract, and art to communicate and center yourself. And what we found is that we have always, their names are Camilla, which goes by Mimi, and Sloan, who goes by Lulu. We've always allowed Mimi and Lulu to have fewer activities than some of their friends. When they would have 4, they would have 3. When they would have 3, my kids would have 2. To clear the time for them to spend with paper, with brush, to really express themselves. So I come at this from the perspective of somebody who's seen children really develop through art. I've been lucky enough that they don't have to deal with this type of disease, but in your experience, what is the power of art as it relates to curing oneself?
I think there's many things one can say about that. And as a scientist, I'm very interested in really trying to understand what the vehicle is by which this happens. And traditional clinical trials are certainly much too expensive to run a study like this. But the kind of system we're talking about could just as easily figure out where art figures, and for that matter, other types of expression, music, dance, whatever. The things I know, which are very relevant, is that a child, a family, any cancer patient who takes an active role in making themselves both more actively engaged in their treatment and healthier, emotionally healthier, and is going to help, or is going to do better, right? And whether that comes from art or a support group or whatever. And I think that art in particular for children has a unique role to play, which I don't know that it's even been explored. I talked to some of the project managers here tonight in thinking about this, and I haven't thought about it very deeply yet, but I'm thinking that it is known that visualization is a very powerful tool, and cancer patients that have consciously visualized what their immune system is doing, for example, the white cells eating up the cancer cells, for whatever reason, do better. And I would like to understand how we might use art to help kids understand what they're going through, understand what their treatment is supposed to do, and move toward visualization, right? As a way to help get their body, everything in their body. The brain is a very powerful organ, right? And get that to unleash the immune system on attacking these things. So I'm a big fan of trying to understand what's going on, and maybe data is the answer here too. But the one thing I would say is, it's been said several times, we have to treat the entire child beyond the diagnosis. This just doesn't mean to do art beyond the thing. It also means, for example, that every kid who is benefiting from the art might also benefit from the types of navigation services that are done at organizations like Cancer Commons. And so we should figure out how we can make use of this network, right? Bring everyone to the table to reinforce. And I have one other important thing to say about pediatrics, pediatric oncology in particular, which is everyone points to pediatric oncology as the stunning success in cancer research, right? When people talk about the dramatic improvements that have been done over the last 50 years, they're almost always talking about what's happened in pediatric indications like leukemia, where, in the old days, 15% of the kids survived, and nowadays it's 80, 85, 90%, 95%. And that was done with many, many incremental steps, small steps, getting better and better and better over an endless chain of clinical trials. Unfortunately, I think that this particular path is certainly seeing limited returns if it hasn't hit a wall. And the reason why is because, first of all, when you have 90% of the kids doing well under the standard therapy, no one wants to go into the clinical trials unless they have to. And then they're very late stage and maybe they don't work. So there's an issue there. The second is that in the old days, we talked about leukemia as a disease. We didn't know that there were like 100 types, subtypes, or maybe many more of leukemias. And we had like 10 therapies that were used in all of cancer, and maybe a few that were used in the blood cancers that were used over and over again. So there was actually a very small space of experiments to be done. There was 10 cancers, leukemia was one, and so was brain and colon and skin cancer and so forth. And there were like 10 therapies. So 10 by 10 box, you had 100 cells, 1 million patients a year who got advanced cancer in the US. So it's like 10,000 patients per cell. You can run lots of clinical trials. Today, if you have hundreds of types of leukemia, and you have not 10 cancer therapies, but hundreds of therapies that could be combined in tens of thousands of plausible regimens, right? You may have 100 million boxes, and you still only have 1 million patients. That's the good news. But you can't run this trial system the way it's been run. And kids is where it's most acute because, fortunately, not a lot of kids get cancer. And today, there's 20 openings in every pediatric oncology trial for each kid. So most of these trials are going to fail, not because we know whether the drug works or not, but because we don't have enough patients to find out. And that's going to be a comeuppance for the investment community that is invested in all these companies that are running these trials. And this is just the tip of the iceberg, because things are about to get either much better or much worse, depending on your view. There was a very interesting law that passed a couple of years ago, a big breakthrough actually, that patient activists pushed through, that said every adult drug that has a rational reason for being tested in pediatric indications needs to be, because these markets are small and not a lot of people develop drugs for the kids, so the kids are left, using adult drugs that are repurposed. But the challenge is that the law requires these drugs to be tested in trials, but it was already 20 openings, and now there's going to be an infinite number of openings. We're really going to get screwed. So the type of system transformation that I'm talking about becomes mandatory, and pediatrics is probably going to be in the lead, because just the sheer limitations are going to force the system to change. And I'm proud to say that I'm on the front lines of that.
Good. Well, thank you very much, Marty.
And again, anyone who's dealing with cancer, come see me. And for the kids, let's do something together.
Yes, we are.